We have ranges for a lot of things in medicine. For example, the range for your thyroid hormone or the range for the amount of calcium in your blood. And in orthopedics, we literally have ranges of motion, how much your joint should move in each plane. What I think is so invaluable about Robin McKenzie's repeated movement testing as an orthopedic test is it gives me a tool to figure out if you have your normal range of motion. It could be low normal, but normal for you, or it could be low normal, but you're actually a high normal kind of person, or above high normal. I don't know exactly when I take the range of motion the first time if that's your normal or not. Of course, I can presume if it's markedly deficient that you're missing it, or if it's extremely hypermobile that maybe there's a ligamentous instability or some kind of pathological process. Most ranges of motion, if they're pathological, are on the limited side versus the too much mobility side. But think about it this way. Say a patient presents to a physician's office with signs and symptoms consistent with low calcium. And the biomarker, the blood marker, shows that the patient's calcium is actually within the range on the low side. Well, then other tests may be appropriate, or you could do a treatment approach aimed at raising the calcium to see if the signs and symptoms abate. Say they do, and the blood marker rises. Well, then that would tell you that while it was within range, it wasn't optimal for that person. That's how I feel about range of motion. That's what repeated movement testing offers me. If I take someone's hip range of motion, for example, and their hip internal rotation is 30 or 35 degrees, for some people that's normal, but for that person it might be insufficient. Maybe they normally have 40, 45 degrees. So if I'm thinking that signs and symptoms are leading me towards a joint problem, I need to have a way of figuring out if that joint is moving adequately for that patient or not. And again, that's what repeated movement testing offers me. So signs and symptoms that are consistent with a joint problem are limited and or painful range of motion, weakness, nerve tension, and functional deficits. So if that hypothetical hip patient is presenting with signs and symptoms in those categories, and the hip internal rotation is limited, I can start my repeated movement testing with moving the low back or moving the hip or maybe even the SI joint and see if those signs and symptoms change if we increase the hip internal rotation. Or maybe we'll find out all those things do not allow us to increase the hip internal rotation. So repeated movement testing will tell us if it's changeable or if it's not. And it just really emphasizes the point that on day one, I can't make an assumption, even if you're in the normal range, if it's the patient's normal, or if gaining more motion would be advantageous. Getting 5 or 10 degrees back can really make a difference in a person's life. In the spine, as I've alluded to before, I can't see those deficits as clearly as with the extremities. With the extremities, hip range of motion is quite clear. Again, it doesn't tell me that it's inadequate or adequate for that patient, but I can get a decent measurement that I think is focal or local to the hip joint. When I have a person do lumbar extension or neck side bending, I really can't perceive if they're missing 5 degrees or 10 degrees or even more degrees, but just in one specific joint of the many joints that are moving at the same time. Because of that conundrum, I want to do testing to see if that changes. And again, if it changes, I want to know if it corresponds to the signs and symptoms. So for patients out there who are just assuming that their range of motion is within the normal range and therefore that cannot be a problem for them, I offer that many times it can be within the normal range, but you're still missing a few degrees, and that can be important to why you have signs and symptoms.